Welcome back to the Deep Dive, the show where we really get into the details, extracting those crucial nuggets of knowledge from your course materials, custom tailored just for you.
Mhm.
And for our deep dive today, we are zeroing in on something that's probably, let's be honest, very much top of mind for a lot of you third-year medical students right now. The intricate world of the renal system.
Yeah, that renal exam looms large, doesn't it? We
Yeah.
know you're likely deep in prep, facing just this mountain of information.
Exactly. So think of this session as your focused high-yield study buddy. We're pulling directly from your lecture materials, anatomy, physiology, path, the works, to help you solidify your understanding
Right, clarify those tricky concepts.
and really pinpoint what's absolutely essential for nailing that exam.
That is precisely our goal today. Our mission, if you will, is to take a comprehensive but hopefully digestible journey through the kidney's complex functions.
Drawing on those core concepts you've been learning.
Exactly.
Mm.
Anatomy, physiology, chemical pathology, even a bit of embryology comes into it sometimes. The real aim is to extract those key insights. How does the kidney normally work? What goes wrong in disease?
And critically, how do you interpret those lab findings? Because that's vital for diagnosis, right? And managing patients.
Absolutely vital. It's all about helping you connect the dots,
Mhm.
not just memorizing isolated facts, but seeing the whole picture. The kidney, a master regulator, core functions, and anatomy.
Okay, so let's start with that big picture then. What actually makes the kidney this master regulator of the body? I mean, we often think of it as just a blood filter.
And it's a huge part of its job, no doubt.
Yeah.
But it's so much more. It's a real multitasker.
Right.
One of its most vital roles is the regulation of water and electrolyte balance. Think sodium, potassium, chloride, water itself. The kidney fine-tunes exactly how much we keep and how much we excrete.
And this is where those big systems come in, like RAAS.
Precisely. The renin-angiotensin-aldosterone system, RAAS, and vasopressin, or ADH, are key players here. Understanding these pathways is absolutely fundamental because they're directly managing blood pressure and fluid status body-wide.
And it connects so clearly to other things you've already learned, doesn't it? Like its role in acid-base homeostasis.
Oh, absolutely. It ties straight back to your respiratory block knowledge. Our bodies are constantly generating acids just through normal metabolism, lactic acid, keto acids.
Right.
And while the lungs deal with CO2, the kidney is the ultimate long-term regulator. It's the most powerful system for maintaining that super narrow physiological pH range, 7.35 to 7.45.
Which is critical for everything. Enzymes, cells.
Everything. Optimal function depends on that balance.
Okay, and then the function everyone thinks of first, getting rid of waste.
Yes, the removal of waste products. The kidney efficiently filters out metabolic waste like urea, which comes from protein breakdown, and creatinine from muscle turnover, plus various toxins.
Which is why when kidney function tanks, these things build up. They become our markers.
Exactly. They're key diagnostic markers.
Right.
And we can't forget the kidney's crucial endocrine functions either. People often overlook these.
Like vitamin D.
Yep, it activates vitamin D, which is essential for calcium balance and healthy bones. It also secretes erythropoietin, or EPO, which tells the bone marrow to make red blood cells.
Which explains why patients with chronic kidney disease often get anemic.
Precisely. That connection is direct. And finally, as we mentioned, it releases renin, which is the first step in that whole RAAS cascade impacting blood pressure. These endocrine roles have really profound clinical consequences when kidney health declines.
Okay, so that's the what. Let's move to the where. Talk about the gross anatomy and its clinical significance. Where exactly are these kidneys sitting, and why does it matter for us clinically?
Okay, location. They're positioned quite elegantly, actually, on the posterior abdominal wall. They're retroperitoneal, meaning they sit behind that peritoneal lining of the abdominal cavity. Typically, they span from about the T12 down to the L3 vertebrae. And interestingly, the right kidney usually sits a bit lower, maybe 2.5 centimeters or so,
Why is that?
because of the liver sitting right above it, pushing it down slightly.
Makes sense.
And this specific location, it has real practical implications. For instance, during a physical exam, if you percuss on the back, below the 12th rib, any dullness you find there is usually just the normal kidney. It's not typically fluid in the chest cavity.
Okay, good distinction.
And this is also the spot, that costovertebral angle, where you check for renal angle tenderness. Pain there can signal inflammation, infection, or kidney trauma.
And for procedures.
Yeah, that posterior retroperitoneal spot is perfect. It allows things like percutaneous kidney biopsies or
Mm.
putting in a nephrostomy tube that's a tube directly into the kidney to drain urine to be done safely from the back, minimizing the risk of hitting other abdominal organs.
Very practical. Now, what about the hilum, that sort of gateway on the inner curve of the kidney? What's going in and out there?
Right, the hilum is the main entry and exit point. If you look at the structures from front to back, the most anterior is the renal vein, which is exiting. Then you have the renal artery entering the kidney.
Yep.
And most posteriorly, you have the renal pelvis, which funnels urine into the ureter, which then exits.
Okay. Vein, artery, ureter, VIU, front to back.
Exactly. And that specific point where the renal pelvis narrows down to become a ureter, that's called the pelvic ureteric junction, or PUJ. Clinically, it's a really common spot for kidney stones to get lodged, causing that classic severe flank pain and obstruction.
Ah, okay. So if we were to slice the kidney open, what internal structures would we see?
If you did a cross-section, you'd immediately see two main regions. There's the outer renal cortex, which is generally lighter in color. This is where the main filtering units, the renal corpuscles, are located.
Mm-hmm.
Then deeper inside, you have the darker renal medulla. It's organized into these distinct triangular shades called renal pyramids. These pyramids contain the straight parts of the tubules, the collecting ducts, and associated blood vessels called the vasa recta.
And the urine flows from these pyramids.
Yes, the tips of the pyramids are called renal papillae. Urine drips from these papillae into small, cup-like structures called minor calyces. Several minor calyces merge to form a larger major callus. And then the major calyces all empty into the central collecting area, the renal pelvis, which acts like a funnel before urine heads down the ureter.
Got it. And you mentioned renal columns, too.
That's right. The renal columns are basically just extensions of that cortical tissue that dip down in between the medullary pyramids. They provide structural support and pathways for blood vessels running to and from the cortex.
Okay, so all this larger structure is there to support the real workhorses, the nephrons. You mentioned about 1.3 million per kidney. That's incredible.
It is a staggering number, and it highlights the kidney's amazing functional reserve, but also its vulnerability if significant numbers are lost. You also mentioned that point about premature babies having fewer nephrons. That's a really important factor, potentially increasing their risk for kidney disease later in life.
Wow. Okay, so tell us about the nephron itself. It's this long, continuous tube, right? But different parts do different things.
Exactly. It's a single layer of epithelial cells forming a continuous tube, but functionally divided. It starts with Bowman's capsule, which is like a cup surrounding the glomerulus, catching the filtrate.
Right, the initial filtered fluid.
Then that filtrate flows into the proximal convoluted tubule, or PCT. It's highly coiled, hence convoluted, which maximizes its length and surface area for reabsorption. It's the most metabolically active part.
Okay.
Next comes the U-shaped loop of Henle, which dips down into the medulla. This is absolutely crucial for the kidney's ability to concentrate urine.
The concentration gradient happens here.
Yes. Then the filtrate moves into the distal convoluted tubule, or DCT, and finally into the collecting duct, where the last fine-tuning adjustments are made before it becomes urine. Multiple DCTs drain into a single collecting duct.
And the blood supply is unique, too. You called it a portal system. Can you unpack that a bit more?
It's a fantastic piece of engineering. Blood flows into the glomerulus via the afferent arteriole. It gets filtered in the glomerular capillaries. But then, instead of draining into a venule like most capillary beds, the glomerular capillaries rejoin to form an efferent arteriole.
Okay. Arterial to capillaries, back to an arteriole. That's different.
Very different. And then this efferent arteriole branches out again into a second capillary network. These are the peritubular capillaries. They wrap really tightly around the PCT, the loop of Henle, and the DCT.
Ah, so they're perfectly placed for all that reabsorption and secretion.
Exactly. They pick up everything that's reabsorbed and deliver anything that needs to be secreted. And a specialized part of these capillaries, the vasa recta, runs parallel to the loop of Henle deep into the medulla, playing a vital role in maintaining that medullary concentration gradient we talked about.
So that whole setup, arterial capillaries, that's the portal system.
Yes, that's the renal portal system. It's essential for the kidney's incredible efficiency in reclaiming vast amounts of water and solutes while precisely controlling what ultimately leaves the body as urine. 2. Glomerular filtration. The initial blood processing.
Okay, with that amazing architecture laid out, let's really zero in on that first crucial step. Glomerular filtration. This is where plasma gets pushed from those glomerular capillaries into Bowman's capsule.
That's the starting point. And the key word here is selectivity. What gets freely filtered? Small stuff, Water, electrolyte sodium, potassium, chloride, bicarbonate, phosphate. Also small molecules like glucose, amino acids, urea, creatinine, uric acid. They all pass through pretty easily.
But the big stuff gets held back.
Exactly.
Mm.
Larger molecules, especially proteins like albumin and all the cellular elements, red cells, white cells, platelets, are retained in the blood. They shouldn't get through that filter.
So the filtrate is basically plasma without the proteins and cells.
Pretty much. Its small solute composition is almost identical to plasma. But critically, it should be essentially protein-free. Finding significant protein in the urine, or proteinuria, is therefore a major red flag. It tells you something's wrong with that filtration barrier.
And that barrier itself, it's not just a simple coffee filter, is it? It's actually 3 distinct layers working together.
Not at all simple. It's a very sophisticated, multi-layered structure. First, you have the fenestrated endothelial cells lining the glomerular capillaries themselves. Fenestrated means they have these little windows or pores.
They're leaky.
Very leaky to water and small solids, about 100 times more permeable than typical capillaries. But importantly, the surface of these cells is coated with negative charges.
And plasma proteins are mostly negatively charged, too.
Bingo. So those negative charges on the endothelium help repel the negatively charged proteins, providing the first layer of screening against protein loss.
Okay, so even layer 1 is selective. What's layer 2?
Layer 2 is the glomerular basement membrane, or GBM. This is an acellular, sort of gelatinous layer sandwiched between the endothelial cells and the next layer. It's also packed with negatively charged molecules, specifically proteoglycans.
So another charge barrier.
A very strong one. It further prevents plasma proteins from getting through based on charge, but its structure still has relatively large spaces, allowing water and small solutes easy passage.
And the final layer, the podocytes. They sound interesting.
They are fascinating cells. Podocytes are the specialized epithelial cells that form the outer wall of Bowman's capsule, facing the GBM. They have these long extensions like arms, and from these arms come intricate, interdigitating foot processes. Yeah, they wrap around the capillaries, and the gaps between these foot processes form what are called filtration slits. This is the final physical barrier the fluid has to squeeze through to enter Bowman's capsule.
Wow, so 3 layers. Fenestrated endothelium, the GBM, and the podocyte filtration slits.
Exactly. And the clinical takeaway is huge. Damage to any one of these components or problems with their formation can disrupt the barrier. This leads to those key signs of glomerular damage in the urine: proteinuria, or hematuria, or both. Understanding these layers helps you think about where a disease process might be occurring.
That detailed structure makes sense. Now, what actually drives the fluid across this complex barrier? We need to talk about the Starling forces and net filtration pressure. It's the same principle as other capillaries, right? But with a key difference.
You got it. Same principle, different magnitudes. There are 4 main forces involved, but one really dominates. The primary driving force pushing fluid out of the capillaries and into Bowman's capsule is the glomerular capillary hydrostatic pressure, CHP. And it's unusually high for a capillary bed, around 55 millimol Hg.
55 millimol Hg, that is high. Why?
It's because blood flows out of the glomerulus through that efferent arteriole, which offers more resistance than a typical venule. This resistance effectively backs up pressure within the glomerular capillaries, keeping it high along their entire length. This sustained high pressure is absolutely critical for driving such a large volume of filtration.
Okay, so that's the big push out. What forces push back or pull fluid in, opposing filtration?
There are 2 main opposing forces. First is the plasma colloid osmotic pressure, CCOP, also called oncotic pressure. This is the pull exerted by the proteins that are left behind in the capillary blood. Since water wants to follow solutes, this pressure, around 30 millimol Hg, tends to pull water back into the capillaries.
Okay, proteins pulling water back in. What's the other opposing force?
That's the Bowman's capsule hydrostatic pressure, THP. This is simply the fluid pressure within Bowman's capsule itself, generated by the filtrate that's already there. It pushes back against the capillary wall, opposing further filtration, and it's typically around 15 millimol Hg.
Right, and there's a 4th force, but it's usually negligible.
Yes, the Bowman's capsule colloid osmotic pressure, TOP. This would be the pull from any proteins in Bowman's capsule. But since proteins shouldn't normally filter significantly, this force is usually considered close to 0 and doesn't play a major role in the calculation.
Okay, so if we do the math, 55 pushing out, minus 30 pulling in, minus 15 pushing back.
That gives you a net filtration pressure, NFP, of about 10 millimol Hg. 55, 30, 15 equals 10. It seems small, doesn't it?
Yeah, only 10 millimilli at sheet.
But that relatively small net pressure, acting over the huge surface area and high permeability of the glomerular capillaries, drives an absolutely enormous glomerular filtration rate, GFR. We're talking about 125 milliliters per minute, or a mind-boggling 180 liters every single day.
180 liters. That's incredible. But we only make, what, 1.5 to 2 liters of urine?
Exactly. That immediately tells you that the vast majority, over 99% of that filtered fluid, along with nearly all the useful phthalate, must be reabsorbed back into the body further down the nephron tubules. Filtration is just step one.
Okay. And the kidney is smart. It doesn't just let GFR fluctuate wildly with every little change in blood pressure. It has these intrinsic mechanisms to keep it stable, autoregulation.
Autoregulation is absolutely vital. It protects the delicate glomerular capillaries from damaging high pressures and ensures a relatively constant delivery of filtrate to the tubules, which is essential for precise control of water and solute excretion. The kidney manages to keep renal blood flow and GFR remarkably constant over a pretty wide range of systemic arterial blood pressure, typically between about 80 and 170 millimillis J.
How does it do that? What are the mechanisms?
There are two main intrinsic mechanisms. First is myogenic autoregulation. It's an inherent property of the smooth muscle in the wall of the afferent arteriole. When blood pressure rises and stretches that muscle, the muscle automatically contracts, constricting the arteriole.
So higher pressure leads to constriction, which limits the increase in blood flow into the glomerulus.
Precisely. It dampens the effect of rising systemic pressure on glomerular pressure.
Clever. What's the other main mechanism?
The second is tubulo-glomerular feedback, or TGF. This is a more complex feedback loop that involves the juxtaglomerular apparatus, or JGA.
Okay, the JGA that involves the macula densa cells, right?
Exactly. The JGA is this specialized structure where the thick ascending limb of the loop of Henle loops back and comes into close contact with the afferent and efferent arterioles of its own glomerulus. The specialized cells in the wall of the tubule at this contact point are called the macula densa. They act like sensors.
What are they sensing?
They primarily sense the concentration of sodium chloride in the tubular fluid reaching them.
Okay, so walk us through how this feedback loop works. Let's say GFR drops for some reason.
Okay, good example. If GFR drops, filtrate flows more slowly through the tubules. This gives the PCT and the loop of Henle more time to reabsorb sodium and chloride.
So less ACL gets delivered to the macula densa.
Exactly. The macula densa senses this low NaCl concentration. In response, it does two key things. First, it sends a signal that causes dilation of the afferent arteriole.
Opening the inflow pipe wider.
Right, which increases blood flow into the glomerulus, raises the glomerular hydrostatic pressure, and helps bring GFR back up towards normal.
Okay, that makes sense. What's the second thing it does?
Simultaneously, that low NaCl signal at the macula densa stimulates the nearby juxtaglomerular cells, which are specialized smooth muscle cells mainly in the wall of the afferent arteriole, to release renin.
And renin kicks off the RAAS pathway.
Precisely. Renin leads to the formation of angiotensin I, which is then converted to angiotensin II, primarily in the lungs. Now, angiotensin II is a potent vasoconstrictor.
Right.
But in the kidney, it has a particularly interesting effect. It preferentially constricts the efferent arteriole, the outflow vessel, more strongly than the afferent arteriole, the inflow vessel.
So it squeezes the outflow more than the inflow. How does that help GFR?
By constricting the exit more, it increases the resistance to blood flowing out of the glomerulus. This effectively dams up blood within the glomerular capillaries, causing the intraglomerular hydrostatic pressure, that main driving force for filtration, to rise, which boosts GFR. It's a really crucial mechanism for maintaining GFR, especially when systemic blood pressure is low.
That is ingenious. But hold on. If angiotensin II is such a powerful vasoconstrictor, why doesn't it clamp down hard on the afferent arteriole too? Wouldn't that counteract the benefit?
Excellent point. And the kidney has a way to handle that. While angiotensin II does have some constricting effect on the afferent arteriole, that effect is significantly blunted by local vasodilators, particularly nitric oxide and O and prostaglandins, which are produced within the kidney. These local factors help keep the afferent arteriole relatively dilated, preserving blood flow into the glomerulus, while allowing angiotensin II's preferential constriction of the efferent arteriole to dominate and support GFR.
Wow, okay. So local factors protect the inflow while Ang2 boosts pressure by squeezing the outflow.
You've got it. It's a beautifully orchestrated system.
And understanding these forces and regulatory loops is absolutely critical in clinical situations, right? You see the effects everywhere.
Everywhere. Think about a patient in circulatory shock, or with severe heart failure, or who is profoundly dehydrated. Their circulating volume is low, Cardiac output might be down. This directly lowers that key glomerular capillary hydrostatic pressure, and GFR plummets.
Makes sense.
Or consider the opposite problem, a patient with a urinary obstruction, like a big kidney stone blocking the ureter. Now you have increased pressure backing up into the tubules, and Bowman's capsule, increased THP, which directly opposes filtration and lowers GFR.
Okay.
Changes in colloid osmotic pressure matter too. In nephrotic syndrome, where patients lose lots of protein in their urine, their plasma comp drops, which can actually increase GFR initially.
Right.
Conversely, in severe dehydration or burns, plasma protein concentration might rise, increasing COP and reducing GFR.
And drugs. We mentioned NSAIDs and ACE inhibitors.
Crucial examples. NSAIDs inhibit prostaglandin synthesis. Since prostaglandins normally help dilate the afferent arteriole, especially when RAAS is active, blocking them can lead to afferent constriction and a drop in GFR, particularly in patients who are already volume depleted or have underlying kidney disease.
Okay, dangerous combo sometimes.
ANCE inhibitors, or ARBs, by blocking the effects of angiotensin II, reduce that preferential efferent constriction. While this is often beneficial for long-term kidney protection, in situations where GFR is heavily dependent on that ANG2 effect, like bilateral renal artery stenosis or severe volume depletion, starting these drugs can cause an acute drop in GFR. You always have to consider the interplay of these forces and drugs in your patients. 3. Tubular function, reabsorption and secretion.
Okay, so the glomerulus has done its job, filtering a massive 180 liters. Now comes the equally critical part, tubular function, getting back all the good stuff the body needs and getting rid of any extra waste. This involves reabsorption and secretion.
Exactly. The tubules are where the fine-tuning happens. Reabsorption is the process of selectively moving substances that the body wants to keep water, glucose, amino acids, vital electrolytes from the tubular fluid back into the blood in the peritubular capillaries.
How does that happen? Is it passive or active?
Both. It uses a whole toolkit of transport mechanisms. There's active transport, which requires energy, usually from ATP hydrolysis. The classic example is the sodium-potassium ATPase pump on the basolateral membrane of tubular cells, which pumps sodium out and potassium in, setting up gradients.
Okay.
Then there's secondary active transport, where the movement of one substance down its concentration gradient, often sodium moving into the cell, provides the energy to move another substance against its gradient. This is how glucose and amino acids are reabsorbed.
Yeah, piggybacking on the sodium gradient.
Precisely. And then there's passive transport, like diffusion, where substances move down their concentration or electrical gradients, like chloride, often following sodium. And water moves passively by osmosis, following the solutes being reabsorbed.
Okay, so that's reabsorption, bringing things back. What about secretion?
Secretion is essentially the reverse process. It's the active transport of specific waste products, or excess ions, from the blood in the peritubular capillaries into the tubular fluid. This adds to what was already filtered, ensuring efficient removal from the body.
What kinds of things get secreted?
Things like excess hydrogen ions for acid-base balance, potassium ions, especially in the distal nephron, organic acids and bases, certain drugs, and some creatinine gets secreted too, in addition to being filtered.
So the final amount of something in the urine, its excretion, is a result of all three processes.
Exactly. Excretion, filtration, reabsorption, plus secretion. And that intricate relationship between the tubules and the surrounding peritubular capillaries, that close proximity, is what makes this massive exchange possible.
Okay, let's walk through the nephron segment by segment now, because each part has its specialties. Starting with the proximal convoluted tubule, PCT. You called it the workhorse earlier.
It really is.
Yeah.
The PCT is where the bulk of reabsorption happens. It reclaims about 60–80% of the filtered water and solutes. Its cells are packed with mitochondria to fuel all the active transport, and they have a dense brush border of microvilli facing the lumen, which massively increases the surface area for transport.
Wow. So what are the star players being reabsorbed here? Glucose and amino acids, you mentioned.
Absolutely. Virtually 100% of the filtered glucose and amino acids are reabsorbed in the PCT using those secondary active cotransporters linked to sodium. These transporters are incredibly efficient.
But they can be overwhelmed, right? That's the concept of transport maximum.
Precisely. These carrier proteins have a limited capacity. If the amount of glucose filtered into the tubule, the filtered load, exceeds the maximum rate at which these carriers can transport it back into the cells, the TERM, then the excess glucose stays in the tubular fluid and ends up in the urine.
Which is exactly what happens in uncontrolled diabetes mellitus glucosuria.
Exactly. The filtered load of glucose is just too high for the PCT transporters to handle. It's important to note, though, that sodium itself doesn't really have a team in the same way, because the kidney can regulate the number of sodium channels, particularly in the distal nephron, under the influence of hormones like aldosterone.
Okay. What about sodium and water in the PCT?
A huge amount of sodium is reabsorbed here, about 70–80% of the filtered load, driven by that NACA ATPase pump. Chloride tends to follow passively, driven by the electrical gradient created by sodium movement. And critically, water follows passively by osmosis. As all these solutes leave the tubule, the tubular fluid becomes slightly less concentrated than the surrounding interstitium, and water just flows down its osmotic gradient. So the fluid leaving the PCT is still isotonic to plasma, around 300 ml/sm in Chiron, but its volume is drastically reduced.
What else gets reabsorbed significantly in the PCT?
Lots. About 80% of filtered potassium, most of the filtered calcium, this part is independent of PTH, 80–90% of phosphate, though PTH inhibits phosphate reabsorption here, and around 80–85% of filtered bicarbonate. Bicarbonate reabsorption here is tightly linked to hydrogen ion secretion, crucial for acid-base balance. A good chunk of urea is also passively reabsorbed. It's just incredibly busy reclaiming everything the body needs.
Okay, PCT handles the bulk. Now let's move to the loop of Henle. Its main game is concentrating the urine, right? Setting up that gradient.
That's its primary unique role. The loop of Henle creates and maintains the hypertonic medullary interstitium, that salty environment deep in the kidney, which is absolutely essential for the kidney's ability to produce concentrated urine later on in the collecting duct. The osmolarity gradient goes from about 300 miles Kal near the cortex up to 1,200 miles Kal or even higher in the deepest part of the medulla.
How does it achieve that? It involves the different permeabilities of its limbs.
Exactly. The descending limb is highly permeable to water, but relatively impermeable to solutes like NaCl. So as the filtrate travels down into the salty medulla, water passively leaves the tubule by osmosis, concentrating the fluid inside.
Okay, water out, solutes stay, fluid gets concentrated. What about the ascending limb?
The ascending limb is the opposite. It's essentially impermeable to water, but it actively transports NaCl out of the tubule and into the surrounding interstitium. The thin ascending limb does this passively down its concentration gradient, while the thick ascending limb, TAL, uses active transport.
And the TL has that famous transporter.
A NAK2Cl symporter, or co-transporter. This powerful pump actively moves 1 sodium, 1 potassium, and 2 chloride ions from the tubular fluid into the cell, and then sodium is pumped out into the interstitium by the NAK ATPase. This process effectively pumps salt into the medulla without letting water follow, making the interstitium salty and the tubular fluid dilute as it ascends.
And this NAK2Cl transporter is where loop diuretics work.
Precisely. Loop diuretics, like furosemide, Lasix, directly inhibit this transporter in the thick ascending limb. By blocking salt reabsorption here, they disrupt the creation of the medullary gradient and prevent water reabsorption later, leading to a massive excretion of salt and water. That's why they are such potent diuretics, used for significant volume overload, like in heart failure or severe edema.
Okay. And this whole process, water leaving the descending limb, salt leaving the ascending limb, creates that gradient. That's the countercurrent multiplier system.
Yes, that's the essence of the countercurrent multiplier. The opposing flows, countercurrent, in the descending and ascending limbs, coupled with the differential transport properties, multiply the concentration gradient along the length of the loop. It's a beautifully efficient system for creating that salty medulla. Oh, and the TAL is also important for reabsorbing magnesium and calcium, driven by the positive electrical potential in the lumen created by K+ recycling.
Got it. Okay, after the loop, we reach the distal convoluted tubule, DCT. What's its main job? More fine-tuning.
Exactly. The DCT is where a lot of the final adjustments, the fine-tuning, happen, especially for electrolytes and acid-base balance. It plays a key role in regulating sodium, potassium, and hydrogen ion homeostasis.
And this is where aldosterone really comes into play.
Yes, the DCT and the connecting tubule collecting duct are the primary sites of action for aldosterone. Aldosterone stimulates the insertion of more epithelial sodium channels, ENASR, on the luminal membrane, and NAK ATPase pumps on the base lateral membrane. This increases sodium reabsorption in exchange for potassium and hydrogen ion secretion. So the amount of sodium reabsorbed here is variable and hormonally controlled.
And most of the potassium that ends up in the urine actually gets secreted here.
That's right. While most filtered potassium is reabsorbed earlier, the amount of potassium excreted is primarily determined by the rate of secretion in the distal nephron, DCT and collecting duct, regulated by factors like aldosterone and plasma potassium levels.
Okay. And then finally the collecting duct. It works closely with the DCT, but has its own major role too.
Yes, the collecting duct continues the fine-tuning of sodium and potassium, and it's also a major site of hydrogen ion secretion, contributing significantly to acid-base balance. But its most famous and critical role is in determining the final urine concentration by regulating water reabsorption, and this is almost entirely under the control of vasopressin, or ADH, antidiuretic hormone.
So ADH is the key for water reabsorption here. How does it work?
The collecting duct's permeability to water is naturally very low. However, when ADH is present, released from the pituitary in response to dehydration or high plasma osmolality, it binds to receptors on the collecting duct cells. This triggers a cascade that leads to the insertion of preformed water channels, called aquaporin II channels, into the luminal membrane.
So ADH basically inserts water cores into the membrane.
Exactly. These aquaporins make the collecting duct highly permeable to water. Now, as the tubular fluid flows down the collecting duct through that salty medullary gradient established by the loop of Henle, water rushes out of the tubule by osmosis, following the gradient, and gets reabsorbed into the blood via the vasa recta. This allows the body to conserve water and produce concentrated urine.
And if there's no ADH?
If ADH is absent, for example, you're well hydrated or in conditions like diabetes insipidus, the aquaporins are not inserted, the collecting duct remains impermeable to water, and you excrete large volumes of very dilute urine. ADH is the switch that controls final water permeability.
That really highlights the importance of water balance regulation. We filter 180 liters, reabsorb 99%. It's incredibly precise. You mentioned ADH and thirst are the main regulators.
Yes. The body defends its extracellular fluid osmolality with incredible vigilance, primarily using ADH and the first mechanism. Both are controlled by osmoreceptors in the hypothalamus that sense plasma osmolality.
Yeah.
Even a tiny increase in osmolality, just 1 to 2%, triggers both ADH release from the posterior pituitary and the sensation of thirst.
So ADH makes you retain water, and thirst makes you drink water.
Exactly. ADH causes the kidneys to reabsorb pure water, diluting the blood back towards normal. Thirst prompts you to seek and ingest water. Significant decreases in blood volume, more than 10–15%, also strongly stimulate both ADH and thirst, acting via baroreceptors, as the body prioritizes maintaining volume even at the expense of osmolality sometimes.
Now, you mentioned osmolality versus tonicity earlier. This often trips students up. Can you clarify that distinction again, maybe with urea or ethanol as examples?
It's a really important distinction. Osmolality is the total concentration of all solute particles dissolved in a kilogram of water, osm kg. Tonicity, on the other hand, refers to the effect a solution has on cell volume. It depends only on the concentration of impermanent solutes that cannot freely cross the cell membrane and therefore exert an osmotic pressure that causes water to shift.
Okay, so tonicity is about water shifts and cell volume changes.
Precisely. Now consider urea or ethanol. If you add these to the blood, they will definitely increase the measured plasma osmolality. However, both urea and ethanol are freely permeable across most cell membranes. They rapidly equilibrate between the intracellular and extracellular compartments.
So they don't create a lasting osmotic gradient to pull water.
Exactly. Because they distribute evenly, they don't cause a significant shift of water into or out of cells. Therefore, while they increase osmolality, they do not significantly affect tonicity or cell volume. This is critically important because changes in tonicity, particularly affecting brain cells, can cause dangerous swelling, cerebral edema, or shrinkage, cerebral dehydration. Sodium is the main determinant of ECF tonicity.
That distinction is key for understanding the osmolar gap. What is that again, and why calculate it?
The osmolar gap is simply the difference between the plasma osmolality that you measure in the lab and the osmolality that you calculate based on the major solutes. The calculation is usually something like calculated osmolality 2x sodium plus glucose 18 plus urea 2.8 using typical US units, adjust constants for millimole.
Okay, measured minus calculated, what's normal?
Normally this gap is small, typically less than 10 osmoles in kilogram. A significantly raised osmolar gap, greater than 1015, is a big red flag. It tells you that there's some other osmotically active substance present in the blood that wasn't included in your calculation.
Like what?
The classic examples are toxic alcohols, methanol, windshield washer fluid, ethylene glycol, antifreeze, isopropyl alcohol, rubbing alcohol, and sometimes other substances like propylene glycol or mannitol. Finding a high osmolar gap can be a crucial clue to diagnosing these poisonings, especially when combined with a metabolic acidosis, which often develops as these alcohols are metabolized to toxic acids. 4. Key biomarkers of renal function: urea and creatinine.
Okay, let's shift to how we actually measure kidney function in the clinic. The two workhorse biomarkers everyone uses are urea and creatinine. Let's tackle urea first. Where does it come from, and how does the kidney handle it?
Right, urea, sometimes called blood urea nitrogen or BUN in the U.S., is the main end product of protein metabolism. When amino acids are broken down, they release ammonia, which is toxic. The liver converts this ammonia into urea through the urea cycle, making it much less toxic and ready for excretion.
And the kidney gets rid of most of it.
Yes, about 90% of the urea produced is excreted by the kidneys. It's freely filtered at the glomerulus. But its journey through the tubules is passive and a bit variable. It gets passively reabsorbed, particularly in the proximal tubule and the collecting duct, and the amount reabsorbed depends heavily on how much water is being reabsorbed.
Ah, so if the kidney is conserving a lot of water, like in dehydration, more urea gets pulled back too.
Exactly. If urine flow is slow and water reabsorption is high, urea gets more time and opportunity to diffuse back into the blood. This is why urea levels can be influenced by factors completely unrelated to the GFR itself.
So what factors, besides actual kidney failure, can push urea levels up?
A lot of things. Decreased renal excretion is the obvious one, seen in acute or chronic renal failure, intrinsic causes, but also, very importantly, pre-renal causes like dehydration, shock, heart failure. Anything reducing renal blood flow will cause that increased passive reabsorption and raise urea disproportionately. Postrenal obstruction also blocks excretion and raises urea.
Okay, so pre-intrinsic and post-renal issues raise it. What about production?
Yes, increased production can also elevate urea. Think of a high-protein meal or a significant gastrointestinal bleed. The digested blood acts like a huge protein load. Also, states of increased protein breakdown, catabolism, like during severe infection, trauma, or high-dose steroid treatment, will increase urea production.
So high urea always needs context. It doesn't automatically mean the kidneys have failed. What about low urea? Is that clinically significant?
Usually less so, but it
Yeah.
can happen. Decreased urea might be seen in severe liver disease because the liver isn't synthesizing urea properly. Very low protein intake or states of increased protein synthesis, like in growing infants or during pregnancy, can lower it. And overhydration, hemodilution can also make it appear low.
Okay, let's move to creatinine. This one's generally seen as a bit more reliable for tracking GFR, right? Why is that?
Yes, generally it is. Creatinine is produced from the breakdown of phosphocreatine, which is an energy store in muscle. The amount produced each day is relatively constant for a given individual because it depends primarily on their muscle mass. It's less affected by diet, though eating large amounts of cooked meat can slightly increase it, or hydration status compared to urea.
And how does the kidney handle creatinine?
Creatinine is freely filtered at the glomerulus, just like urea. Critically, however, it undergoes very little, if any, tubular reabsorption. There is some tubular secretion, mainly in the proximal tubule, which adds a bit to the excreted amount. The secretion becomes proportionally more significant as GFR declines in chronic kidney disease.
Ah, so it's mostly filtered, barely reabsorbed, and a bit secreted. That sounds more directly related to GFR than urea.
It is generally more closely related to GFR. However, it still has significant limitations you absolutely must be aware of.
Okay, what are the main pitfalls with creatinine?
First, it can be quite insensitive in mild renal impairment. GFR can drop by as much as 50% before serum creatinine rises above the upper limit of the normal reference range, especially in someone with low muscle mass.
So a normal creatinine doesn't guarantee normal kidney function?
Absolutely not, especially in certain populations.
Oh.
Because it's dependent on muscle mass, baseline creatinine levels are naturally lower in infants, children, women, and particularly the elderly or frail individuals. A creatinine level that looks normal on the lab report for an 85-year-old woman with little muscle could actually represent significant renal insufficiency. You always need to interpret it in context, or better yet, use it to calculate an estimated GFR, eGFR.
Okay, context is key. What else affects it? Drugs.
Yes, certain drugs can interfere with that tubular secretion of creatinine, making the serum level appear falsely high, even if GFR hasn't changed. Common culprits include cimetidine, an old H2 blocker, probenecid, used for gout, and trimethoprim, an antibiotic component of Bactrim septa. Always check the medication list.
Good point. And low creatinine, is that ever important?
Decreased serum creatinine is usually not clinically worrisome. It typically just reflects low muscle mass or sometimes overhydration.
So given the limitations of both, using them together, specifically the urea to creatinine ratio, becomes really useful, especially in acute situations.
Absolutely. The urea-creatinine ratio, often called the BUN.creatinine ratio in the U.S., is a classic tool, particularly helpful in the initial workup of acute kidney injury, AKI, to help distinguish between prerenal causes and intrinsic renal damage, like acute tubular necrosis, ATN.
How does the ratio help? What do you expect to see?
In prerenal AKI, where the kidney's tubules are still working but perfusion is low, you typically see a disproportionately high urea level relative to creatinine. This results in a high ratio, often cited as greater than 70, when using SI units, bmol for urea and real for creatinine, or greater than 20.1 using US units, mgdl for both BUN and creatinine.
Why does urea go up so much more?
Because in that low flow state, the functional tubules are avidly reabsorbing sodium and water to try and restore volume. Urea gets passively reabsorbed along with the water, so its level climbs significantly. Creatinine, however, isn't reabsorbed much, so its level rises less dramatically. The kidney's in conservation mode.
Okay, high ratio suggests pre-renal conservation. What about in ATN?
In acute tubular necrosis, ATN, the tubules themselves are damaged. They lose their ability to selectively reabsorb solutes, including urea. Therefore, both urea and creatinine tend to accumulate in the blood more proportionally to the drop in GFR. This results in a normal ratio, typically in the range of 46 SI units or 1015.1 US units.
So normal ratio points more towards intrinsic tubular damage.
Generally, yes. It suggests the tubules have lost their selective reabsorptive capacity. However, you always have to remember those other things that can raise urea disproportionately, like a GI bleed, high protein intake, or catabolic states steroids, as these can mimic a prerenal ratio even if the primary problem isn't hypoperfusion. The ratio is a clue, not a definitive diagnosis on its own. Water and electrolyte imbalances, sodium and potassium.
Okay, let's pivot to some major clinical challenges. Water and electrolyte imbalances, focusing on the big two, sodium and potassium. Starting with sodium, the king of the extracellular cations. Remind us why it's so crucial.
Sodium is absolutely dominant in the extracellular fluid, ECF. It accounts for about 90% of the ECF cations and is the primary determinant of ECF osmotic pressure and therefore water distribution between the intracellular and extracellular compartments. Wherever sodium goes, water tends to follow. So loss of sodium from the body always results in a reduction of ECF volume.
And how does the body keep sodium levels in check? What are the regulatory mechanisms?
Several key players regulate sodium balance. Aldosterone, released from the adrenal cortex, acts on the distal tubules and collecting ducts to increase sodium reabsorption via ENSC channels in exchange for potassium and hydrogen ion secretion. Aldosterone release is stimulated by angiotensin II, part of RAAS, low ECF sodium or high ECF potassium.
Okay, aldosterone hold on to sodium. What else?
Thirst and ADH are critical, primarily responding to changes in plasma osmolality, which is largely driven by sodium concentration. High sodium osmolality stimulates thirst, increasing water intake, and ADH release, increasing water reabsorption by the kidneys.
Right, and there's one that does the opposite, promotes sodium loss.
Yes, atrial natriuretic peptide, AMP. It's released by the heart's atria when they are stretched by increased blood volume. AMP acts to increase sodium excretion, natriuresis, by blocking sodium reabsorption in the collecting ducts, increasing GFR slightly, and antagonizing the effects of RAAS and ADH. It's the body's way of trying to offload excess volume.
Okay, let's tackle the common clinical problem, hyponatremia, when serum sodium drops below 135 millimole. What kind of symptoms should make us think of this, and how do we start the diagnostic process?
The clinical presentation of hyponatremia is primarily neurological. This is because the low ECF sodium concentration, low tonicity, causes water to shift into brain cells, leading to cerebral swelling or edema. The severity depends on how low the sodium is and how quickly it dropped.
What kind of neurological signs?
It can range from relatively mild symptoms like nausea, vomiting, headache, and lethargy at sodium levels maybe between 125 and 130 millimole to much more severe signs below 125, like muscle weakness, ataxia, confusion, seizures, coma, and even respiratory depression. Acute hyponatremia falling below 120 millimole is a genuine medical emergency requiring immediate attention.
Okay, so if you suspect hyponatremia, what's the absolute first lab test you need?
The very first step always is to check the serum osmolality. This is crucial because it helps you categorize the hyponatremia and narrow down the potential causes.
Right, because hyponatremia doesn't always mean low osmolality.
Exactly. There are three possibilities based on osmolality. First, if the serum osmolality is normal, roughly 275, 295 mils ME/GE, you should suspect pseudohyponatremia. This isn't true hyponatremia. It's usually a lab artifact.
How does that happen?
It can occur when there are extremely high levels of lipids, triglycerides, or proteins, like in multiple myeloma, in the blood. These substances take up space in the plasma volume, so when the lab measures sodium in a fixed volume of plasma using certain methods, indirect ion selective electrodes, the sodium concentration appears falsely low because there's less water per unit volume. Direct IEC methods aren't affected.
Okay, so check lipids and protein if osmolality is normal. What if osmolality is high?
If serum osmolality is high, 295 mL/mg, it's called hyperosmolar hyponatremia, or sometimes translational hyponatremia. This happens when there is another osmotically active substance in the ECF, like extremely high glucose as in DKA or HHS or mannitol infusion. These substances pull water out of the cells and into the ECF, diluting the sodium concentration. You need to treat the underlying cause. You will give insulin for hyperglycemia.
Makes sense. And the most common type is when osmolality is actually low.
Yes, the most frequent scenario is hyposmolar hyponatremia, where both serum sodium and serum osmolality are truly low. 275 CLM is mkg. This indicates an excess of water relative to sodium in the body. Once you've confirmed low osmolality, the next critical step is to assess the patient's volume status. Are they hypovolemic, euvolemic, or hypervolemic?
How do we differentiate based on volume status and what causes each type? Let's start with hypovolemic, low volume.
In depletional or hypovolemic hyponatremia, the patient has lost both sodium and water, but proportionally more sodium than water. Clinically, they'll show signs of volume depletion, orthostatic hypotension, dizziness on standing, tachycardia, fast heart rate, maybe dry mucous membranes, decreased skin turgor.
What causes this salt and water loss?
Common causes include renal losses, like from using loop or thiazide diuretics, or mineralocorticoid deficiency, Addison's disease, congenital adrenal hyperplasia, or extrarenal losses like severe vomiting or diarrhea, or significant losses into a third space like in pancreatitis.
And how do the urine studies help here, specifically urine sodium?
Critically, if the volume loss is extrarenal, like diarrhea, the kidneys will try desperately to hold on to sodium. So the urine sodium concentration will be low, typically less than 10 or 20 millimole. If the loss is renal, like from diuretics, the kidneys can't conserve sodium effectively, so the urine sodium will be inappropriately high, usually 20 millimole, despite the hypovolemia.
Okay, that's a key differentiator. Now, what about dilutional hyponatremia, where the problem is too much water? This can be euvolemic or hypervolemic.
Exactly. In dilutional states, there's an excess of total body water relative to sodium. If the patient appears clinically euvolemic, normal volume status, no edema, no signs of dehydration, the classic cause is the syndrome of inappropriate ADH, SIADH. What causes that? Many things can cause the inappropriate release of ADH. Certain cancers, especially small cell lung cancer, producing ectopic ADH, various CNS disorders like stroke, hemorrhage infection, pulmonary diseases, pain, stress, nausea, and numerous drugs like SSRIs, carbamazepine, cyclophosphamide. In SIADH, the excess ADH causes the kidneys to retain too much water, diluting the sodium. The urine will be inappropriately concentrated, high osmolality relative to the low plasma osmolality, and the urine sodium will typically be high, 20 to 40 millimole, because the patient isn't volume depleted. Other euvolemic causes include primary polydipsia, drinking excessive amounts of water, hypothyroidism, or adrenal insufficiency, cortisol deficiency.
Okay. And the hypervolemic fluid overloaded type.
Hypervolemic hyponatremia occurs in conditions where there's an increase in both total body sodium and total body water, but water increases much more than sodium. Patients typically have clinical signs of fluid overload, like peripheral edema or pulmonary edema. Classic causes include congestive heart failure, CHF, liver cirrhosis, and nephrotic syndrome. In these states, although total body sodium is high, the effective circulating volume is perceived as low by the body, leading to activation of RAS and ADH, causing avid sodium and water retention. Advanced renal failure itself can also lead to hypervolemic hyponatremia simply because the kidneys can't excrete the excess water load. In these cases, urine sodium is typically low, 10-20 millimole, due to the avid renal sodium retention. That's a great framework. Now, a huge clinical warning always comes with treating hyponatremia, especially chronic cases. The risk of central pontine myelinosis, CPM. Can you explain that? It's a devastating complication and something you absolutely must avoid. CPM, also known as osmotic demyelination syndrome, occurs when chronic hyponatremia, present for 48 hours, is corrected too rapidly.
Why is rapid correction so dangerous in chronic cases?
Because in chronic hyponatremia, the brain cells have adapted to the low surrounding tonicity. They've extruded some of their internal solutes, osmolytes, to prevent excessive swelling. If you then rapidly increase the ECF sodium concentration, the ECF becomes hypertonic relative to the adapted brain cells. Water rushes out of the brain cells, causing them to shrink rapidly, which can lead to disruption of the myelin sheath, particularly in the pons. This causes severe, often irreversible neurological damage, quadriplegia, pseudobulbar palsy, locked-in syndrome.
Terrifying. So what's the safe rate of correction?
The general guideline is to correct slowly and cautiously. The rate of increase in serum sodium should generally not exceed 10-12 millimole in the first 24 hours, and perhaps no more than 18 millimole in the first 48 hours. Aiming for an increase of about 0.5 millimoles per hour or even less in high-risk patients is often recommended. Slow and steady wins the race here.
Absolutely crucial point. Now let's flip to the other side. Hypernatremia, serum sodium greater than 150 millimole. You said this is always a state of hyperosmolality.
Yes, hypernatremia by definition means the plasma is hyperosmolar, high solute concentration. It almost always reflects a deficit of water relative to sodium in the body. The primary cause is usually excess water loss that hasn't been replaced, or insufficient water intake. Less commonly, it can be due to excessive sodium intake or retention.
And clinically, like hyponatremia, the main symptoms are neurological, but for the opposite reason.
Exactly. In hypernatremia, the high ECF tonicity pulls water out of brain cells, causing them to shrink. This cerebral dehydration leads to neurological symptoms like lethargy, confusion, irritability, muscle twitching, seizures, and coma. The brain shrinkage can also tear small bridging veins, leading to intracranial hemorrhage.
What are the common causes? How do we categorize them?
We usually think about it in terms of water loss versus sodium gain, often assessing volume status too, though most patients are hypovolemic or euvolemic. The most common cause is unreplaced water losses. This can be due to insensible losses, increased sweating, fever, exercise and heat, or respiratory losses without adequate fluid intake. Renal losses, osmotic diuresis like in hyperglycemia or, critically, diabetes insipidus, DI, GI losses, severe diarrhea, especially osmotic diarrhea, GI losses. Another major category is simply decreased water intake. This is common in patients who can't access water or communicate thirst, like infants, elderly patients with altered mental status, or intubated patients. Pure sodium gain is less common, but can happen with administration of hypertonic saline or sodium bicarbonate.
You mentioned diabetes insipidus as a key cause of renal water loss. Tell us more about that.
Diabetes insipidus, DI, is a disorder characterized by the inability to concentrate urine due to problems with ADH. There are two main types: central DI, where the pituitary gland doesn't produce or release enough ADH, and nephrogenic DI, where the kidneys are resistant to the effects of ADH even if it's present.
How do patients with DI present?
They typically present with intense thirst, polydipsia, and the excretion of large volumes of very dilute urine, polyuria, often several liters a day. Because they're losing so much free water, they tend to become hypernatremic if they can't keep up with water intake. The key differentiator from diabetes mellitus, which also causes polyuria, is that in DI, the urine osmolality is inappropriately low, 300 moism killium, often 100, despite the high plasma osmolality sodium.
And how do you tell central from nephrogenic DI?
A water deprivation test followed by administration of desmopressin, synthetic ADH, is often used. In central DI, water deprivation won't concentrate the urine much, but giving desmopressin will cause the urine osmolality to rise significantly, usually 50%. In nephrogenic DI, the kidneys are resistant, so neither water deprivation nor giving desmopressin will significantly increase urine osmolality.
Okay. And just like with hyponatremia, rapid correction of hypernatremia is dangerous.
Yes, for the opposite reason. If you correct hypernatremia too quickly by giving lots of hypotonic fluid, water will rush back into the dehydrated brain cells, which have generated idiogenic osmolates to try and maintain their volume. This rapid influx of water can cause cerebral edema, which can be fatal. So again, correction must be slow and careful, typically aiming to lower the sodium by no more than 0.5 millimolar per hour or 10-12 millimolar per day.
Okay. Crucial symmetry there. Correct both hyponatremia and hypernatremia slowly. Now let's switch to potassium, the major intracellular cation. Why is it so important, even though most of it is inside cells?
Potassium K+ is critical because the ratio of intracellular to extracellular potassium concentration is the primary determinant of the resting membrane potential of cells. Especially excitable cells like nerve and muscle includes the heart muscle. Even small changes in extracellular potassium can have profound effects on cell excitability and function. Only about 2% of total body potassium is in the ECF, so the body has to regulate that ECF concentration very tightly.
How does the kidney handle potassium?
It's interesting, most of the potassium filtered at the glomerulus, around 90%, is actually reabsorbed in the proximal tubule and the loop of Henle. So the amount of potassium that ultimately appears in the urine is determined almost entirely by secretion in the distal nephron, the DCT, and collecting ducts, specifically by the principal cells there via channels like ROMK and BK.
So excretion depends mainly on secretion. What factors control that secretion?
Several factors influence distal potassium secretion. A key one is sodium delivery to the distal tubule. More sodium reaching the DCT, like when using loop or thiazide diuretics, enhances potassium secretion, which is why these diuretics often cause hypokalemia. Conversely, low distal sodium delivery, like in low GFR states, impairs potassium secretion, contributing to hyperkalemia.
Aldosterone plays a role too, right?
Big time. Aldosterone directly stimulates potassium secretion by increasing the activity of the NAK-AT pace and the number of potassium channels, or ROMK, in the principal cells. In fact, hyperkalemia itself is a potent direct stimulus for aldosterone release from the adrenal gland, creating a negative feedback loop.
What about acid-base status?
There's generally a reciprocal relationship. Acidosis tends to decrease potassium secretion. H+ ions compete with K+ for exchange with Na+, leading to hyperkalemia. Conversely, alkalosis tends to increase potassium secretion, contributing to hypokalemia. However, there are important exceptions, like acute diarrhea or distal RTA, type 1, where you can have acidosis with hypokalemia due to direct losses or specific tubular defects.
And insulin.
Insulin promotes the uptake of potassium into cells by stimulating the NAK-AT pace pump. This effect is clinically exploited when we treat hyperkalemia with an insulin-glucose infusion. Catecholines, like epinephrine, via beta-2 receptors, also enhance potassium uptake into cells.
Okay, let's talk about the disorders. Hypokalemia, first serum K+ below 3.5 millimole. What causes it, and what are the signs?
Hypokalemia can result from decreased intake, rarely the sole cause. Increased losses, either renal or extrarenal, like from the GI tract, or redistribution of potassium from the ECF into cells, like during treatment of DKA with insulin, metabolic alkalosis, use of beta agonists like salbutamol, or refeeding syndrome. You also need to rule out pseudohypokalemia, which can happen if a blood sample with very high white cell count sits too long, allowing WBCs to take up potassium in vitro.
And the clinical manifestations, what are we worried about?
Because potassium is crucial for membrane potential, hypokalemia causes hyperpolarization of cells. The biggest concern is cardiac arrhythmias. You might see ECG changes like flattening or inversion of T waves, appearance of U waves, prolonged PR interval, and increased risk of dangerous ventricular arrhythmias like torsades de pointe. Other effects include muscle weakness, which can progress to paralysis and even respiratory failure, rhabdomyolysis, muscle breakdown, impaired renal tubular function leading to nephrogenic DI, constipation or paralytic ALIS due to smooth muscle dysfunction, and impaired insulin release, potentially worsening hyperglycemia.
How do we figure out if the potassium loss is from the kidneys or somewhere else?
Measuring urine potassium excretion is key. If the loss is extrarenal, like diarrhea or vomiting, though vomiting causes renal loss indirectly via aldosterone, the kidneys should try to conserve potassium, so urine potassium will be low. Urine to 24-hour urine K plus 20-30 millimole day, or a spot urine K plus creatinine ratio 1.5 millimole or 13 millimole. If the loss is renal due to diuretics, RTA, hyperaldosteronism, certain genetic disorders, the urine potassium will be inappropriately high, irrigample 24-hour urine K plus 30 millimole day, despite the low serum level.
And treatment, oral or IV?
Oral potassium replacement, like potassium chloride, is preferred whenever possible, as it's safer. 4-potassium is used for severe hypokalemia, for example, 2.5 millimole, or if the patient can't take oral meds or has significant ECG changes or arrhythmias. But 4-potassium must be given cautiously. Never as an IV push, it can cause fatal cardiac arrest. Always diluted and infused slowly, typically no faster than 10-20 millimole per hour, usually with continuous ECG monitoring in severe cases. And critically, you often need to check and correct magnesium deficiency as well, because low magnesium impairs the kidney's ability to retain potassium, making hypokalemia refractory to treatment.
Okay, vital points on hypokalemia. Now, the really scary one, hyperkalemia, potassium greater than 5.5 millimole. Why is this considered such a medical emergency?
Hyperkalemia is incredibly dangerous, primarily because of its effects on the heart. High extracellular potassium reduces the resting membrane potential, makes it less negative, closer to the threshold, initially increasing excitability, but then leading to slowed conduction and decreased excitability, ultimately causing potentially fatal cardiac arrhythmias and cardiac arrest. The risk becomes significant above 6.0 millimole and is very high above 7.0 or 8.0 millimole or more.
What are the classic ECG changes we look for as warnings?
The ECG changes often progress in a somewhat predictable pattern as potassium rises. The earliest and most characteristic sign is peaked T waves, tall, narrow-tented. As levels increase further, you can see prolongation of the PR interval, loss of the P wave, and then widening of the QRS complex. Eventually, the QRS can merge with the T wave, forming a sine wave pattern, which often precedes ventricular fibrillation or systole. These ECG changes are critical early warnings.
Besides the heart, what other signs can occur?
Patients might experience muscle weakness, paresthesias, tingling, or even ascending flaccid paralysis.
What are the main causes of hyperkalemia?
The causes fall into three main categories. First, decreased renal excretion, which is the most common cause overall. This occurs in AKI, especially oliguric phases, end-stage renal disease, CKD stage 5, use of certain drugs like potassium-sparing diuretics, spironolactone, amiloride, ACE inhibitors, ARBs, NSAIDs, and adrenal insufficiency, Addison's disease, lacking aldosterone. Second, redistribution of potassium from inside cells to the ECF. This happens in metabolic acidosis. H+ ions move into cells, K+ moves out. Massive tissue breakdown like rhabdomyolysis or tumor lysis syndrome, releasing intracellular K+, or sometimes with certain drugs like digoxin toxicity or beta blockers, non-selective ones. Third, increased intake, but this is rarely the sole cause unless renal function is already significantly impaired.
And you mentioned pseudohyperkalemia before. It's crucial to rule that out.
Absolutely critical. Before initiating potentially dangerous emergency treatment, you must consider if the high potassium level is real. Pseudohyperkalemia is a falsely elevated result due to potassium release from cells after the blood has been drawn. Common causes include hemolysis, if the blood draw was difficult or the sample was handled roughly; delayed separation, if the sample sits too long before serum plasma is separated, K+ can leak from cells; extreme leukocytosis or thrombocytosis, very high white cell or platelet counts can release K+ during clotting or if analysis is delayed; contamination, if the blood was drawn into or near an EDTA tube, purple top used for CBCs. EDTA chelates calcium, so a clue might be a simultaneously very low calcium level on the same sample. If suspected, repeat the sample, ensuring proper collection and prompt handling.
Okay, so assuming it's true, severe hyperkalemia, what's the immediate management strategy?
Acute severe hyperkalemia, Scalmi 6.5 ml or with ECG changes, is a medical emergency requiring rapid intervention. The priorities are: 1. Stabilize the cardiac membrane. This is done immediately with IV calcium gluconate, or calcium chloride via central line. Calcium directly antagonizes the effect of potassium on the heart muscle's excitability, protecting against arrhythmias. Importantly, it does not lower the serum potassium level itself. 2. Shift potassium intracellularly. This buys you time. The fastest way is usually an IV infusion of regular insulin along with glucose. Glucose prevents hypoglycemia from the insulin. Sodium bicarbonate infusion can also be used, especially if the patient is acidotic, as alkalosis drives K+ into cells. High-dose inhaled beta-2 agonists, like salbutamol also promote intracellular shift. 3. Remove potassium from the body. This is the definitive treatment.
Options include using loop diuretics, like furosemide if kidney function allows, administering potassium-binding resins in the gut, like sodium polystyrene sulfonate kyaxylate, or newer agents like beta or melokelma, which promote fecal excretion, slower onset, or in severe or refractory cases, hemodialysis, which is the most effective and rapid way to remove potassium. Dialysis is often an absolute indication if K+ is 7 mmol or if life-threatening ECG changes persist despite other measures.
Wow, a multi-pronged attack. And just a quick note on lab samples for potassium.
Yes, important pre-analytical points. Plasma potassium from a green tofeparin tube is generally preferred over serum potassium, red gold top, because potassium can be released from platelets during clotting, making serum levels slightly higher. Also, do not refrigerate whole blood samples before separation, as chilling inhibits the NEK ATPase pump, causing potassium to leak out of red cells and falsely elevating the result. Samples should be transported at room temperature and separated, serum plasma removed from cells, ideally within 1–2 hours of collection. 6. Acid-base homeostasis and disorders.
All right, let's tackle another fundamental area where the kidney is king, acid-base homeostasis. We need our blood pH kept in that incredibly tight range, 7.35 to 7.45. Why is the body so obsessed with this number?
It's obsessed for good reason. That narrow pH range is absolutely essential for the optimal function of basically all enzymes and cellular processes in the body. Think about protein structure. It's highly sensitive to pH changes. Even small deviations can alter enzyme activity, disrupt metabolic pathways, interfere with oxygen transport by hemoglobin, and affect cell membrane excitability.
And where does all the acid come from that needs regulating?
Normal metabolism is constantly generating acids. Volatile acid is carbonic acid, H2CO3, which comes from CO2 produced during aerobic metabolism. The lungs handle this by blowing off CO2. But metabolism also produces non-volatile acids, or fixed acids, that the lungs can't eliminate. Examples include lactic acid from anaerobic metabolism, keto acids like beta-hydroxybutyrate and acetoacetate from fatty acid breakdown, sulfuric acid from metabolism of sulfur-containing amino acids, and phosphoric acid. The body produces about 5,100 millimole of fixed acid every day that the kidneys ultimately need to excrete.
So what happens if pH goes out of whack? What are the clinical consequences?
Significant pH disturbances can be life-threatening. Acidosis, low pH, can impair myocardial contractility, reduce the effectiveness of catecholamines, like adrenaline, cause vasodilation leading to low blood pressure, induce hyperkalemia, as H+ shifts into cells and K+ shifts out, decrease oxygen delivery to tissues, and eventually lead to coma. Alkalosis, high pH, can cause vasoconstriction, including cerebral vasoconstriction, induce hypokalemia and hypocalcemia, leading to tetany, seizures, increase neuronal excitability, and also impair oxygen delivery due to the Bohr effect shift. Maintaining pH is truly critical for survival.
How does the body manage this constant acid load and keep pH so stable? You mentioned 3 main systems earlier.
Yes, there are 3 lines of defense. First, chemical buffers in the blood and tissues act almost instantaneously. The most important ECF buffer is the bicarbonate carbonic acid system, HCO3, H2CO3. But phosphate in proteins, like hemoglobin, also act as buffers. These provide immediate but limited buffering capacity.
Okay, buffers are the first responders. What's next?
Second, the respiratory system responds within minutes. The respiratory center and the brainstem senses changes in PCO2 and pH. If there's acidosis, ventilation increases to blow off more CO2, reducing carbonic acid. If there's alkalosis, ventilation decreases to retain CO2. It's a rapid compensatory mechanism.
And the third, slowest but most powerful system?
That's the kidneys. They take hours to days to respond fully, but they provide the most powerful and definitive long-term control of acid-base balance. They can directly excrete the fixed acids produced by metabolism and precisely regulate the body's bicarbonate stores.
Let's dive into the kidney's specific roles here. You mentioned bicarbonate reabsorption, hydrogen ion excretion, and generating new bicarbonate. How does it reabsorb bicarbonate?
It's impermeable, right?
Exactly. The tubular membranes are largely impermeable to bicarbonate ions, HCO3. So the kidney uses a clever indirect method, primarily in the proximal tubule, to reclaim virtually all the bicarbonate that's filtered, about 4,300 millimole away, please. Here's how it works. 1. Hydrogen ions, H+, are secreted into the tubular lumen via Na plus H+ exchange or H+ ATPase. 2. In the lumen, the secreted H+ combines with filtered HCO3 to form carbonic acid, H2CO3. 3. An enzyme called carbonic anhydrase, located on the brush border of the PCT cells, rapidly catalyzes the breakdown of H2CO3 into water, H2O, and carbon dioxide, CO2. 4. CO2 is lipid-soluble and easily diffuses across the luminal membrane into the tubular cell. 5. Inside the cell, another form of carbonic anhydrase rapidly recombines the CO2 with intracellular water to reform H2CO3. 6. This intercellular H2CO3 then dissociates back into H+ and HCO3. 7. The H+ is recycled back into lumen to combine with more filtered bicarbonate, while the bicarbonate HCO3 is transported across the basolateral membrane via mechanisms like Na plus HCO3 co-transport back into the bloodstream.
Wow. So for every H+ secreted, 1 bicarbonate is effectively reabsorbed back into the blood, even though it wasn't the same bicarbonate molecule that was filtered.
Precisely. It's an ingenious reclamation process that prevents massive loss of the body's main buffer.
Okay, so that saves the filtered bicarbonate. How does the kidney get rid of the excess acid produced daily? How does it excrete hydrogen ions?
This happens mainly in the distal nephron, DCT, and collecting ducts, particularly by specialized cells called intercalated cells. They actively secrete hydrogen ions into the tubular fluid using H+ ATPase pumps. However, urine pH can't drop much below about 4.0, 4.5 because a steep gradient opposes further H+ secretion. So the secreted H+ ions need to be buffered in the urine.
What buffers them in the urine?
2 main urinary buffer systems are used. First, filtered phosphate, mostly HPO42, accepts a proton to become H2PO4, which is then excreted. This accounts for some of the acid excretion. But the most important and adaptable buffer system is ammonia, NH3.
Ammonia, where does that come from?
Renal tubular cells, especially in the PCT, actively metabolize the amino acid glutamine. This process generates ammonia, NH3, and also, conveniently, new bicarbonate ions which are reabsorbed. The ammonia produced is lipid-soluble and diffuses into the tubular lumen.
And in the lumen, it buffers the secreted H+.
Exactly. In the lumen, ammonia, NH3, combines with the secreted H+ to form ammonium ions, NH4+. Ammonium is poorly lipid-soluble, so it gets trapped in the tubular fluid and is excreted in the urine. This process allows the kidney to excrete large amounts of acid without lowering the urine pH too drastically. Plus, as mentioned, the generation of ammonia from glutamine simultaneously produces new bicarbonate that gets added back to the body fluids, replenishing the buffer stores that were consumed, buffering the metabolic acids.
So the ammonia system is key for both excreting acid and regenerating bicarbonate. That's incredibly efficient.
It really is. The kidney's ability to regulate ammonia production and excretion is its main way of adjusting acid excretion to match the body's metabolic load over time.
Okay, now let's bring this to the bedside. We use blood gas analysis, BGA, constantly. What are the key parameters we're looking at, and what do they primarily tell us?
A standard BGA gives you several crucial pieces of information. pH, the overall measure of acidity or alkalinity, normal 7.35, 7.45. Low equals acidosis, high equals alkalosis. This is the starting point. PCO2, partial pressure of carbon dioxide. This reflects the respiratory component. High PCO2 suggests respiratory acidosis, hypoventilation. Low PCO2 suggests respiratory alkalosis, hyperventilation. Normal range is typically 35-45 millimole HEA-HD. Bicarbonate, HTO3. This represents the metabolic component. On a BGA, it's usually calculated from pH and PCO2 using the Henderson-Hasselbalch equation. Low HTO3 suggests metabolic acidosis. High HTO3 suggests metabolic alkalosis. Normal range is about 22-26 millimole. Sometimes you'll see standard bicarbonate, which is corrected to a normal PCO2 to isolate the metabolic component. Base excess, BE. This is another calculated parameter reflecting the metabolic component. It represents the amount of strong acid or base needed to titrate 1 liter of blood back to a normal pH of 7.40 at a normal PCO2 of 40 millimole G. A negative BE, base deficit, indicates metabolic acidosis, while a positive BE indicates metabolic alkalosis. Normal range is typically medically 2 plus 2 millimole PO2.
Partial pressure of oxygen indicates the patient's oxygenation status, total CO2, TCO2. This is often measured on a basic metabolic panel electrolytes rather than a BGA. It primarily reflects the bicarbonate concentration, 95%, plus dissolved CO2 and carbonic acid. It gives a good estimate of the bicarbonate level.
Okay, that's the basic interpretation. Now, for metabolic acidosis, the anion gap, AG, is a really powerful diagnostic tool. Remind us what it is and how to calculate it.
The anion gap is based on the principle of electroneutrality in plasma. The total concentration of positively charged ions, educations, must equal the total concentration of negatively charged ions, anions. The AG is a calculated value that represents the difference between the major measured pascation, sodium, sometimes potassium is included, and the major measured anions, chloride and bicarbonate.
So AG will AG plus K plus Cl plus HCO3, or sometimes just Na plus Cl plus HCO3.
Both formulas are used, including potassium gives a slightly higher normal range. A common formula is simply Ag equals Na plus Cl plus HTO3 with a normal range roughly 812 millimole. Or if K plus is included, Na plus K plus, Cl plus HTO3, normal range about 916 millimole. The key is that it represents the concentration of unmeasured anions in the plasma, things like albumin, which is negatively charged, phosphate, sulfate, and organic anions.
And its main use is in sorting out metabolic acidosis. How does it help?
Its primary clinical utility is in differentiating the causes of metabolic acidosis. We divide metabolic acidosis into two main types based on the anion gap. 1. High anion gap metabolic acidosis, HAGMA. 2. Normal anion gap metabolic acidosis, HAGMA.
Okay, what causes a high anion gap metabolic acidosis, HAGMA?
AGMA occurs when the acidosis is caused by the accumulation of an unmeasured acid. The protons, H+, from this acid are buffered by bicarbonate, so the bicarbonate level falls. However, the anion part of the acid, e.g. lactate, keto acids, formate, replaces the bicarbonate, maintaining electroneutrality but increasing the gap because this new anion isn't measured in the standard Ag calculation.
So bicarbonate goes down, but it's replaced by something else that widens the gap. What are the common causes of HAGMA?
Mnemonics. Yes. The classic mnemonics help you remember the causes. Mud piles is a popular one. Methanol, uremia, severe renal failure, accumulation of phosphatidylsulfates. Diabetic ketoacidosis, DKA. Coraldehyde propylene glycol, paracetamol, acetaminophen overdose. Iron INH, isoniazid, infections. Sepsis, causing lactic acidosis. Lactic acidosis, most common cause overall. Ethylene glycol. Salicylates.
Another useful one is Goldmark. Another useful one is Goldmark glycols, ethylene and propylene. Another useful one is Goldmark oxaproline associated with chronic paracetamol use. Another useful one is Goldmark lactic acidosis. Another useful one is Goldmark D-lactic acidosis, rare bacterial overgrowth in gut. Another useful one is Goldmark methanol. Another useful one is Goldmark aspirin, salicylates. Another useful one is Goldmark renal failure, uremia. Another useful one is Goldmark ketoacidosis, diabetic alcoholic starvation. Another useful one is Goldmark. Finding a hegma immediately points you towards these potentially serious underlying conditions.
Right. What about the other type, normal anion gap metabolic acidosis? NAGMA, what's happening there?
NAGMA, also called hyperchloremic metabolic acidosis, occurs when bicarbonate is lost from the body, but it's replaced by chloride ions, Cl, to maintain electroneutrality. Because chloride is measured in the anion gap calculation, the gap remains normal, but the chloride level is usually high, hyperchloremia.
So bicarb is lost, chloride goes up, gap stays normal. What causes this direct loss of bicarbonate or gain of chloride?
The main causes are gastrointestinal bicarbonate loss, most commonly severe diarrhea, which involves losing large amounts of bicarbonate-rich fluid. Also, pancreatic or biliary fistulas, renal bicarbonate loss, or impaired acid excretion. This includes various types of renal tubular acidosis, RTA. Type 1, distal RTA, defect in distal H+ secretion. Urine pH is high, 5.5, often causes hypokalemia and kidney stones. Type 2, proximal RTA, defect in proximal HCO3 reabsorption. Urine pH can be variable, but often 5.5 once plasma bicarb is low, often causes hypokalemia, can be part of Fanconi syndrome. Type 4 RTA, associated with aldosterone deficiency or resistance, impaired K+ and H+ secretion, often causes hyperkalemia. Administration of chloride-containing fluids, giving large volumes of normal saline, carbonic anhydrase inhibitor, can cause a mild NAGMA because saline has a chloride concentration higher than plasma. Administration of chloride-containing fluids, certain drugs like acetazolamide, carbonic anhydrase inhibitor, which causes renal bicarbonate wasting. Administration of chloride-containing fluids. So finding an NAGMA points you towards GI losses or specific renal tubular problems.
That anion gap is incredibly useful. Okay, let's quickly summarize the simple acid-base disorders regarding their primary change and how the body tries to compensate.
Sure. Metabolic acidosis. Primary problem, low HCO3. Compensation, lungs increase ventilation to blow off CO2, low PCO2. Kidneys try to excrete more acid and regenerate bicarb, slow. Metabolic alkalosis. Primary problem, high HCO3. Compensation, lungs decrease ventilation to retain CO2, high PCO2, but this is limited by hypoxia. Kidneys try to excrete more bicarb, slow, often impaired by volume depletion or low K+. Respiratory acidosis. Primary problem, high PCO2 hypoventilation. Compensation. Kidneys retain HCO3 and increase H+ excretion, slow. Acute versus chronic. In chronic, bicarbonate will be significantly elevated due to renal compensation, respiratory alkalosis. Primary problem, low PCO2 hyperventilation. Compensation buffers consume some HCO3 quickly. Kidneys excrete HCO3 slow. Acute versus chronic. In chronic, bicarbonate will be significantly lower due to renal compensation.
And often patients don't fit neatly into one box. They have mixed disorders.
Very common in critically ill patients. For example, a patient with sepsis might have lactic acidosis, HAGMA, and respiratory failure causing respiratory acidosis, high PCO2. Or the salicylate overdose example, early respiratory alkalosis followed by HEGA. Interpreting complex BGAs requires looking at all the numbers, pH, PCO2, HCO3, and G, considering the expected compensation for any primary disorder, and crucially, integrating it all with patient's history and clinical picture. Sometimes the history is the most important clue to unraveling a mixed picture. 7. Acute kidney injury, AKI. Diagnosis and management.
Okay, let's move into our final major topic, acute kidney injury, or AKI. This is something you'll see constantly on the wards. How do we formally define AKI, and why is it such a big deal?
AKI is defined by a sudden decline in kidney function occurring over hours to days. This is typically recognized by a rise in serum creatinine and/or a fall in urine output. The key is the acute nature of the change. It results in the retention of nitrogenous wastes, like urea and creatinine, and dysregulation of fluids, electrolytes, and acid-base balance.
And it's different from chronic kidney disease, CKD.
Yes, that's a crucial distinction. AKI is potentially reversible, whereas CKD is a progressive loss of kidney function over months or years and is generally irreversible. AKI is a major clinical problem. It affects a significant percentage of hospitalized patients, especially those in the ICU, and it's strongly linked to increased morbidity, longer hospital stays, higher healthcare costs, and significantly increased risk of death.
Given its impact, what should we look for clinically? How might AKI present?
The presentation is incredibly variable. Some patients might be completely asymptomatic, with AKI only picked up on routine lab tests. Others can become critically ill very quickly. Common signs and symptoms relate to the consequences of failing kidney function, waste product accumulation, nausea, vomiting, loss of appetite, confusion, lethargy, asterixis, uremic flap, pericardial rub and severe uremia, fluid overload, peripheral edema, pulmonary edema, shortness of breath, weight gain, hypertension, hyponatremia if water retention exceeds solute retention, electrolyte imbalances, especially hyperkalemia, which can cause muscle weakness and life-threatening arrhythmias, palpitations, ECG changes. Hypocalcemia and hyperphosphatemia are also common. Metabolic acidosis may cause small breathing, cheap, rapid respirations as the lungs try to compensate. Decreased urine output, oliguria. Though importantly, AKI can occur without decreased urine output, non-oliguric AKI.
Okay, let's break down the causes and pathophysiology. We usually categorize AKI into three main buckets based on where the problem originates: prerenal, intrinsic, and postrenal. Let's start with prerenal AKI.
Prerenal AKI is the most common type, accounting for maybe 50–70% of cases. Essentially a functional problem caused by decreased blood flow, perfusion to the kidneys. The key here is that the kidney structure itself is initially undamaged. The problem is simply not enough blood getting there to allow adequate filtration.
What causes this poor perfusion?
Anything that leads to reduced effective circulating volume or low blood pressure. Common causes include true hypovolemia, hemorrhage, severe dehydration from GI losses, vomiting, diarrhea, excessive diuresis, burns, decreased cardiac output, heart failure, cardiogenic shock, pulmonary embolism, pericardial tamponade, systemic vasodilation, sepsis, anaphylaxis, liver failure, hepatorenal syndrome, renal vasoconstriction, sometimes caused by drugs like NSAIDs or conditions like hepatorenal syndrome, drugs interfering with autoregulation. As we discussed, NSAIDs, blocking afferent dilation, and ACE inhibitor ARBs, blocking efferent constriction, can precipitate prerenal AKI, especially in vulnerable patients.
So the kidney is thirsty for blood, but okay structurally, for now.
Exactly. The kidney tries to compensate using those autoregulatory mechanisms, myogenic response, TGF, RAS, to maintain GFR. But if the hypoperfusion is too severe, for example, systolic BP 80 millimillar Hg, or prolonged, or if these compensatory mechanisms are impaired, example, by underlying vascular disease or interfering drugs, GFR will fall significantly. And critically, if this prerenal state persists long enough, the resulting ischemia can lead to actual structural damage, transitioning into intrinsic AKI.
Okay, so that leads us to intrinsic renal AKI. This means the kidney tissue itself is damaged.
Yes, intrinsic or intrarenal AKI means there's damage to the actual structures within the kidney, the glomeruli, tubules, interstitium, or blood vessels. The most common cause of intrinsic AKI, particularly in hospitalized patients, is acute tubular necrosis, ATN.
And ATN is often the result of that prolonged prerenal state.
Very often, severe or prolonged ischemia from any cause of prerenal AKI can damage and kill the renal tubular cells, leading to ischemic ATN. The other major cause of ATN is direct nephrotoxicity.
What kind of toxins?
It can be exogenous from outside the body, like certain antibiotics, especially aminoglycosides like gentamicin, amphotericin B, IV contrast dye, contrast-induced nephropathy, chemotherapy drugs, cisplatin, heavy metals, or endogenous from inside the body, like myoglobin released during rhabdomyolysis, hemoglobin from massive hemolysis, or light chains in multiple myeloma. Sepsis itself can also directly contribute to ATN through complex inflammatory and microvascular mechanisms.
So ATN, ischemic or toxic, is the big one for intrinsic AKI. What are other intrinsic causes affecting different parts of the kidney?
You can also have glomerular diseases, like acute glomerulonephritis or vasculitis affecting the glomerular capillaries, often presenting with hematuria, proteinuria, red cell casts. Interstitial diseases, acute interstitial nephritis, AIN, often an allergic reaction to drugs like penicillins and NSAIDs, PPIs, causing inflammation in the tissue between the tubules, often presents with fever, rash, eosinophils in urine, white cell casts, can also be caused by infections or infiltrative diseases, vascular diseases, things like renal artery thrombosis or embolism, renal vein thrombosis, malignant hypertension, or thrombotic microangiopathies, like HUS-TTP. These are less common causes of AKI overall.
You mentioned the ischemic spectrum earlier, from prerenal to ATN. Can you recap that?
Sure, think of it as a continuum. 1. Prerenal state. Reduced perfusion, GFR drops, but tubules are okay, and avidly reabsorbing NAD plus water, low FeNA concentrated urine. Reversible if perfusion is restored quickly. 2. Ischemic injury incipient ATN. Perfusion remains low, tubular cells start getting injured, losing polarity. Maybe some apoptosis necrosis begins. Function declines further. Still potentially reversible. 3. Established ATN. Widespread tubular cell necrosis and sloughing occur. Cells block the tubules. GFR plummets. Tubules lose reabsorptive capacity. Hyphena dilute urine. Recovery is possible but takes time, days to weeks, for cells to regenerate if the underlying cause is removed. 4. Cortical necrosis. If ischemia is extremely severe and prolonged, irreversible death of the entire cortex can occur. This is rare but devastating. 4. Cortical necrosis. The key message is that the earlier you recognize and reverse the prerenal state, the better the chance of preventing progression to established, less easily reversible ATN.
Okay. And the final category, postrenal AKI, the plumbing problem.
Exactly. Postrenal AKI is